I'm recording.
All right. So hi guys again, or hi everyone. My name's Taylor. I again am the intern for PFP for the summer. Stephanie is the executive director. PFP is the parenting group for not just parents, for parents, prospective parents, and grandparents that identify as part of the LGBTQ plus community. This is the fourth in our series of prospective parenting classes over the summer. We are holding 2 more virtual sessions. Next week, we will have one on surrogacy, and the week after that will be foster parent recruitment. I'll put the registration link for next week in the chat. And we also have recordings of all of our past events on our Facebook page, which I'll send around when I send a follow-up email to you all after this event. And we're very happy to have Ray and Leandra here. Ray is going to talk about in-home midwifery, and Leandra is going to talk about midwifery in the hospital. So I will hand it over to Ray.
Hey all. I've done this talk in person a few times. It feels very weird and different to do it on the screen. But just to kind of, I guess a good place to start is just kind of talking about there's a couple of different options for care providers in the childbearing year. There are midwives, and there are different kinds of midwives. There are family medicine doctors, and there are obstetricians. And I think I'm gonna share a kind of share my screen just to give you kind of a very busy chart that I'm just gonna have in the background while I'm talking. This is from a talk I did a few years ago. And, there's not any right or wrong way to give birth in the US. It's about kind of just figuring out what model of care speaks most to you. And so, the kind of midwife I am, I'm a certified professional midwife, and we exclusively do home birth and birth center birth. And so it's a model of care that first and foremost is for folks who are low risk. And, a low risk pregnancy means that, someone is not having any major health things going on in their body. So someone who doesn't have pre-existing diabetes or a heart condition or different blood disorders or some autoimmune disorder, or cancer, just things that would make their body medically maybe need a hospital setting to give birth. And also folks that are interested in a lot more personal experience, a lot more agency and autonomy, and also an unmedicated birth experience. It definitely is a model that I think speaks to a lot of queer people, because you have a personal relationship with your care provider that you get to know over the course of care. So most midwives like myself either work in solo practices where you'd have, when you hire me as a midwife, you just have me. And so all prenatal care is done with the same person over the course of time that you get to know, and they get to know your family, your values, your pronouns, your parenting terms. So there's not as much need for advocacy because you have relationship, and also these care providers are more likely to act as advocates for you because of the personal relationship. And then also when you give birth in your home environment, you have a lot more control. So my clients who are planning home births with me, it's gather supplies for the birth. They learn a lot about the birthing process and how they want to cope. They will, kind of prepare their team and prepare their lives in their home to give birth in that environment. And also have a lot of confidence in themselves in the process. And, not necessarily starting out there, but building that through prenatal care and their own education. And so this is kind of a model of care that works for folks that, want a lot of autonomy, are interested in having an unmedicated birth experience. And, I think in thinking about different birth environments, there's just different risk benefits with each environment, and it's just choosing the environment that's right for you. So, I think, it's really interesting, in kind of the research on trans folks in pregnancy, one thing that we do see is that trans people have really, really, really high rates of using midwives and really high rates of home birth. So in the general population, about 9% of people are giving birth with midwives, and 1.36% are having out of hospital or home or birth center births by out of hospital. And when it comes to like trans and non-binary people, like 50% are using midwives and 20% are having out of hospital births, which is like really, really different, and speaks to the way that like the midwifery model of care, helps like improve outcomes and like helps like having a more personal relationship with the care provider. So other providers that, offer birth care, they're nurse midwives. Leandra's also is going to talk about that a little bit more in a bit. And so it's the midwifery model of care. And when I say that, I mean, it's a model of care that treats pregnant people as the expert on their own body and health, and then works more in a partnership to help support having a healthy pregnancy and birth experience. And it's literally the oldest profession in the world. They're second oldest, I think with sex work, it's like chicken and the egg a little bit. But, we've been around for a very, very, very long time. And in the US, it's evolved in like two different models. So nurse midwives primarily work in hospitals. Some do home birth as well. And then typically physicians work in hospitals as well. And so there's different models for that. So family medicine doctors can do deliveries in hospitals. Some do. I think in Philadelphia, HUP is the only place that has a family medicine practice delivering in hospital. But they also believe in like continuity of care, which is something that midwives prioritize, which is having a relationship with a care provider throughout the course of your pregnancy and birth, because having a relationship improves outcomes. There are also obstetricians, which are, when we typically think about, birth in the US, we think about OBs. And it's a medical model of care. And this is like, some people feel safer with an obstetrician for their birth, and that is absolutely where they should give birth, if that's like the care provider they feel safest is. But they are trained in more complicated care. So folks that have, pre-existing conditions or have more complicated pregnancies or will need surgery or want surgery to give birth. These are folks like obstetricians are trained to like manage, like medically complex birth, while midwives are trained to manage and like, we're the experts on like normal birth. And part of being the expert on normal birth is identifying when something shifts out of the range of normal to like help get the appropriate level of care.
Ray, sorry, this is Stephanie. There was a question in the chat about.
Yes, I'm not looking at the chat. I love.
No, that's okay. I'll just interrupt you if there are any that seem like you should answer.
I'm a New York Jew. I love being interrupted. Yeah.
Perfect. What is a birth center? Someone asked.
A birth center is like an intermediary. So in a hospital, they have lots of medical equipment to like, assist people in giving birth. They have surgery, they have epidurals, they have IV fluids, they have lots of medications. In a home birth, we bring the emergency equipment. So we have, medications to control bleeding. We have things to resuscitate babies. We have medications to treat shock. We can we can suture. Like we have like the emergency stuff, but it's also like an unmedicated birth. And in a birth center, they have the same equipment, but you go to the location of the birth center to give birth. So many birth centers are affiliated or very close to a hospital. So like the Bryn Mawr Birth Center, which is the only birth center in this area. There's one in Delaware, then in Wilmington, that some folks will go to too. But in like the Life Cycle Women Care Birth Center in Bryn Mawr, PA is across the street from a hospital. So some folks, feel like while they want like a natural birth experience, or when I say natural, I mean unmedicated, they want more autonomy, they want midwifery care. They also want easier access to a hospital. They want midwives that have hospital privileges. So in the event that, like during the birth process, they're like, oh, I want an epidural. This sucks. They go across the hospital with their midwife, and their midwife continues to provide their care, which is not something, myself as a home birth midwife can do. When I bring someone to the hospital, I transfer care. And they also, it's like a group practice. So they, you would have like the person who's on shifts, which means that you would have like perhaps a midwife that's like less tired than me sometimes, but also means that you may not meet or know the care provider who delivers your baby very well. Birth centers also have one pain management tool called nitrous oxide, which is laughing gas. It's really commonly used throughout Europe and the rest of the world. And it didn't, like, the manufacturer like went away in the 1970s, so it's not as common here. But it is like a tool where you're like, I'm wanting like a pain management tool. I don't think I want an epidural. So it's kind of like an intermediate place for folks where they're like maybe wanting some of the aspects of a home birth and more control, but feel more comfortable going somewhere to give birth. Are there any other questions in the chat?
Not right now.
Okay, cool. That was a great one. So yeah, I think the next slide I just kind of want to.
Sorry, there is one.
Go for it. Yeah.
Why opt to transfer care when admitted to the hospital?
So I feel like I might need more clarification on that, but maybe I can, like, what I'm thinking the question is like, why would you transfer to another provider? Is that what they're asking?
I will wait and see.
Okay.
If the person who asked the question can maybe clarify.
Cool.
We'll come back to it. Go ahead. You can.
Yeah. So I think, so with a care provider like myself, so certified professional midwives don't have privileges in hospitals. So before the pandemic, if like, let's say one of my clients, you know, home birth is for normal birth, same with birth center birth is for normal birth. So if like a complication arises or one of the tools of the hospital that's not available at home, like medications to speed up labor or epidurals, which is like, you know, stronger pain medication than a bathtub and a back rub, then we would go to the hospital. And so like midwives are in home, in every setting are trained to like identify when something's up. And if we identify something's up, we go to the hospital and are greeted by the people that like provide care in the hospital. And before the pandemic, myself and all the other midwives I know would like go with people, help transition care. One of the things, because of the pandemic, there's currently a cap on how many support people you can have at birth. So I'm not able to go with people anymore. It's also another reason people are going to home birth. So like since the pandemic started, like myself and everyone else's practices have like doubled because there's a lot more limitations in like how they're trying to provide safety in the hospital. That is included like not being able to have any additional support person aside from one partner that can't leave the room.
Got it. That answered their question.
Okay, cool. Let's see. How do I get myself to go to the next slide? I might have to X out of this. Here. So this is, you know, when I think about like how to like provide like affirming care to like an affirming like care plan for queer folks, I think about like what are the aspects that we're, you know, navigating. We're navigating, you know, identities that aren't represented well in, you know, common culture. Like if you go sometimes to a doctor's office in pregnancy, there's a bunch of pictures of like skinny straight white women and their pregnant bellies that are like surrounded by flowers, and that often that might represent some folks in our community, but a lot of us get left out in like images and education. And so, you know, the thing that really helps improve care is having a relationship where someone like knows you, knows your family, is willing and active to advocate for you. So that might be, you know, working with a midwifery practice in a hospital or with a family medicine practice that does like education on the labor floor about like pronouns and parenting terms, or working with a doula that, you know, can help you like work with your provider to create an advocacy plan and can provide continuous support throughout pregnancy and birth, or choosing a care provider that, you know, really reflects your values, or, you know, choosing to go out of home. At home, you know, it's also choosing a location of birth that feels most comfortable to you. Ultimately, you know, I obviously like home birth because that's what I do, and it's not right for a lot of folks for a variety of reasons. And ultimately, like, you should give birth where you feel most safe, comfortable, and secure. Like that is going to be the best place for you. And then also get connected to communities. So one of the upsides of COVID is that like the queer pregnancy community has really moved online in full force. So like there is like queer childbirth ed happening with, you know, a BIPOC queer doula in Seattle that I've been sending folks to. There's a queer and pregnant and like preconception and new parent group run by a trans doula in Texas. There's like a lot of like, there's already like really, really great Facebook community for anyone who's trans or non-binary. There's a group called Trans Breast and Chest Feeding People and Allies. It is the largest collection of trans people on Facebook. It's the largest collection of trans people like in the world who are like using their bodies to create pregnancies, birth babies, feed their babies with their body. And they have a separate group for trans folks who are actually pregnant. And that has been like such a lifeline to like many of my trans clients. And I think that world is continuing to expand as we're like all on Zoom all the time. And then also like planning for support. You know, our family structures are not represented and services are not set up well for us. So maybe it's, you know, figuring out how to bring in your community of friends. Maybe it's like having like mental health care like lined up beforehand. Maybe it's a postpartum doula, which is like a trained support person to help people through the early days, or knowing what groups that you want to go to that are like affirming of like people that aren't identifying as moms. And like being able to like have a plan that like makes you feel like safe and like able to carry it out. You know, queer people are at risk for like experiencing more adversity in their life, which means we're more at risk for experiencing postpartum mood disorders. So having a really good support plan is really crucial to like your health and well-being. And then also making a plan for infant feeding. Just to kind of quickly here, I'll go out and go in again, go over some of the like infant feeding options.
I'm going to interrupt you again real quick.
Yeah.
I have a question. What's the difference between a doula and a midwife?
Great question. Doulas are non-medical support people. So I started off as a doula like a decade ago, and I went to a weekend-long training where I learned about birth and how to support people during birth. And then over the course of, you know, months and years of attending births, it's like learning, I felt like it was like learning how to be helpful in a way that I was like, why was I never taught this? But it's just like someone who like knows how to support the childbearing year, can provide education, can provide continuity and like help you navigate systems, and just having someone who has your back. And right now with the pandemic, a lot of folks have like moved to virtual doula support. So having someone that like you can always ask questions of and in your corner. And if you're choosing to have a hospital birth, because there's not as much continuity of like seeing the same provider, having a doula can be really helpful. So you have a relationship that's seeing you through. A midwife is a trained healthcare provider that are experts on, you know, pregnancy and, you know, the, you know, people with uteruses, our reproductive lifespan. So, you know, to become a midwife, I went to school for 3 years. I did like 2 years of clinical training. I did a residency. Like it's a lot more training. And I think one of the simplest ways to put it is like in a birth room, the doula would be like by your head, you know, and whispering words of encouragement, and the midwife would be like by your junk, helping get the baby out. Does that answer it?
Yes, sorry, I was laughing. That was funny.
Cool.
Yes, I think that definitely answered it. There was actually another request for some of the, to share the resources that you mentioned, like the Facebook groups and stuff. But
yeah, when I'm done talking, I'll link some of them in the chat.
Awesome. And then Taylor can also send them out via email tomorrow too.
Yeah, happy to do that. Yeah, there's a few that I'm really loving being able to send people to right now.
Awesome. Great. Thank you.
Yeah. So just to touch on infant feeding, there are lots of ways to feed a baby. If you want to feed a baby with your body, you just need nipples. Sometimes so if someone has, you know, gives birth, there is a process where your hormones will shift to like create milk. And so when someone's like pregnant and has not had top surgery, that's a typical process. And also if you've never breastfed before or chest fed before, it can be really helpful to have support, because like, while you have the supplies and the baby has the instincts, it's a big learning curve. People who have had top surgery can also sometimes chest feed. Top surgery takes out most of the glandular tissue, but if you're pregnant, you may have some glandular development during pregnancy. It depends on the procedure. People who have had like double incision with nipple grafts tend to have the least amount of growth. People with keyhole tend to have more. But like studies on like trans health will have like 18 people in them, so we can't say for certain. I have seen, so for all of my trans clients who've had top surgery have had some glandular development, but mostly pretty minimal with double incision. And then, you know, if sometimes with nipple grafts, like milk will be able to come through the nipple and sometimes it won't. But if there's not able to get a supply from your body, you can use something called a supplemental nursing system, which is basically like a skinny tube that you tape to the nipple and then put into like a bottle of milk with formula. And there's like a very, very, very little bit of research on like people being on testosterone while chest feeding. And like one case study we have was like, oh, it didn't pass through milk, but it will like definitely decrease your supply. There's also options to induce lactation if you're not the person who carried the baby. There's a medical protocol that we use, and it's something that's really helpful to do with a lactation consultant who can kind of help guide you through like establishing a milk supply. And that's something to be done like ideally 6 months prior to when the baby comes into your family. And it's also something that can be done when you're adopting a baby as well. The protocol was developed for adoptive parents. And then also you can feed a baby with a bottle. You know, you can feed them formula. There's also possible to get donor milk. So breast milk that came from someone else's body, and you can either buy it from a bank or get it from donations in community. So, and there's no like right or wrong way. It's just about like what's right for your family. So yeah, and I think the only other thing I wanted to mention before I'll like pass it over to Leandra is that I also do home IUI. And so for folks that, you know, lack sperm and are getting sperm from a bank, you may have talked about this in the donor sperm panel, but with frozen sperm, it's more successful to try and get pregnant if you insert the sperm into the uterus instead of into the cervix. And so something that some folks will do is do intrauterine insemination with a midwife. And in that model of care, I teach people how to track their cycles for insemination, and then I do the actual IUI procedure in their own home. And so it's kind of like an in-between, like from like baster to like fertility clinic, where it's like totally DIY on your own versus like being in a more medical setting. So it's, I think again, like speaks to the similar thing that like midwives feel the need for folks who want like more ownership and agency and want to learn a lot about their body and have more control and more intimacy in the process of conceiving their child. Yeah. Any other questions before I pass it over?
I don't see any other questions right now, but if folks do have other questions, you know, keep them coming, and we'll ask Leandra, and then we can ask Ray also, who hopefully can stick around.
Totally. I'm going to stop sharing so I can get passed it over. But.
All right, and I'm going to set up Leandra's slides. Sorry if you got my Nick Foles background in there. Okay, take it away.
Okay, so my name is Leandra. I work in a like tertiary health center, I guess, which basically means like we really care for people anywhere from like the very low risk to maybe a little bit of the higher risk, more complicated prenatal care. So I first would like to preface with talking about medicine, birth, and us, right? The LGBTQIA+ community. I think Ray was talking a little bit about having very honest conversations with us about, you know, different ideas of safety and risk. So, you know, for some of us, safety could mean a healthy parent and a healthy baby. Other people, it could mean gender affirming care, anti-racist care, or it could also mean having immediate access to an operating room. So these are kind of conversations that I think when you're talking about what is the best environment for you to have a baby and carry a pregnancy with, you know, these are all the things that maybe we need to talk about. Also, medicine has not done a really great job at creating access and dignified care for all prospective parents. This is something I think we are all working towards doing, especially in like the traditional medical, in the traditional medical environments of the hospital and clinics. And also, who is the person in control, right? So Ray was talking about where does that control autonomy lie? Is it in the client? I mean, in traditional medicine, it very much isn't. It's really in the hands of either the doctor or the provider. You know, I think more and more we have seen how much violence that creates, and we've been trying to maybe have more, like, introduce the concept of sharing that space. And that's also where the midwifery model, as it gets adopted by more traditional medical centers, those are the things that they have to kind of reckon with, right? The midwives are always there talking about, well, how do we make this, how do we talk about shared decision making with a client? What does that mean? And that ultimately that means, as providers, giving up some of that power and space to our clients. So I guess some things to kind of, if you think, this is in slide 3, Taylor, by the way, if we are, so if you think, midwifery care may be in the hospital, maybe a way for, if you're considering something like that, I think not all midwives kind of do the same thing at different hospital institutions. And I think it's a good idea to kind of talk about these differences. There are certainly some midwives that are like an N of 1 or an N of 2 within a larger hospital group. And then there's also group midwifery care where there's like 9 or 10 midwives who are, for example, one of our care models that we really pride ourselves in, and one of the things we really fought hard at Jefferson to do, is having 24-hour midwifery coverage, right? So not just during the day when maybe everything is busy, but at night too, just always constantly having a midwifery presence there, which is obviously very difficult if you only have 2 or 1 midwife in your group. And then collaborative practice with OB/GYN generalists and high-risk maternal fetal medicine. So what is the relationship between the midwives and the high-risk or the OB/GYN, like the surgeons, right, of the team? In our practice, this is sometimes a little bit of a struggle, right? How do you collaborate? And collaboration really does mean that our colleagues respect and value what we bring to the table, but also we are able to then share management and care for maybe clients who maybe would be out of our midwifery scope, right? But still be part of their care, still collaborate, still co-manage some of that stuff that maybe if we were in a birth center or at home birth, we would not be able to even, engage in that care anymore, right? So that's something that is very, I think it's very comforting for a lot of our clients. The fact that they develop, for example, high blood pressure in pregnancy, right? They're able to see us also with the backup of our high risk team. And then the third one, and I think the thing that mostly is very important, I think, for us as like what was often called like vulnerable populations, or people who've not traditionally not been respected in medical institutions, is like the academic institution versus the private practice, which I think the main difference is having a residency program there, right? So learners or medical students also, and how will you as a consumer, as the client, interact with those learners? And is that something you want to invite people in? Is your pregnancy and your birth something that you want to be shared with when it comes to those learners, or it isn't? I will say that one of the most fulfilling things of my job is actually teaching residents and talking to them about different models of practice, different models of patient education. And it's really great to see, how they begin with one idea of patient care and then ultimately, graduate really rethinking the way you give care in pregnancy. So that's another thing I think to think about. And then when it comes to prenatal care, right, we talked a little bit about their preconception and family planning discussions. So some of you guys may be like, I'm ready, you know, to do this. I have made all of my arrangements for that to happen. But some of you guys may be like, I never want to carry a pregnancy, or you've never thought about it. And I think it is very important, especially for I think LGBTQIA+ people, to think about what is our relationship to family planning, and having those discussions with our well, first with people who we trust, and our families, whether they may be blood or not, and then maybe bringing those forth in our medical interactions. And then also recommendations versus obligations. So I think when it comes to traditional prenatal care, even within my short career of like less than, or like 5 years, I've seen like recommendations come and go in traditional prenatal care. So I think everyone needs to know this, because it is very silly, I think, when providers make recommendations seem like obligations for clients, and not giving them the room to think and consider and ask where these recommendations are coming from. And this is something that, again, as midwives, we really try to hammer in and change the status quo when it comes to this. But if any of you guys are interacting with providers who kind of get insulted at you asking questions, it is like a commentary on their lack of knowledge, right? And their defensiveness around it, rather than on you.
Leandra, can I just jump in for a second? Sorry.
Oh, yeah,
do you want me to hold questions to the end, or do you want me to interrupt? Do you care?
I am. Let me just finish with this last
Sure.
little thing, and then we can go ahead and do it.
Okay.
And then also adjusting to the twists and turns of prenatal care, right? Like, so how Ray and I kind of met each other, it was through giving prenatal care to like the same clients, right? Either something would happen at home and there would be a transfer, and or even in prenatal care, there would need to be a consultation. And I think that having a seamless way of transferring consulting amongst all these different like spheres of care, whether it's home, a birth center, and a hospital, I think that's how we get to have more autonomy with our clients, like protect that autonomy in our clients, I mean, and how we get to give the best care possible. And I think my AirPods actually gave out, sorry. Hello, can you guys still hear me?
Yes.
Hello? Can you guys still hear me?
Yes, we can.
Okay, great. And in terms of birth in the hospital, this is something even when I begin prenatal care with some of my clients, I begin having them talk about these things, like what their priorities are for them and their families. You know, is your priority pain control? Are you just like deathly afraid of feeling anything? Or is it low medical intervention? Is it always seeing and feeling your baby close to you? Is it, that can you cope with the unpredictability of birth sometimes? Or is it reducing genital trauma, gender affirming birth, any of these things, and I hate to, sometimes it's a really sucky, but I do think that kind of prioritizing those things and seeing what is the most important things to you, and doing our best to protect that in the hospital is something that I try to work with my clients. And then understanding that agendas in the birthing room, especially in the hospital, can sometimes mismatch, right? So there's a nurse there, there's a doctor or a midwife or a family member, and then there's the client. And sometimes those agendas are different, right? Maybe it's about like, we want to get this baby out quickly. Why? Just because we do, right? Because we need a bed, or because we we were worried about something, or we would, and I think that's something to be very transparent about. And what I was saying too is about forming a network of support. So who you're gonna call, FaceTime, have in person. And unfortunately, yeah, COVID has really pared down the amount of in-person support. But I'm very much of the like thought of like, you can FaceTime, you can WhatsApp, you know, you can talk to anyone during a birth to think through a decision, to and to call in, you know, when things are maybe getting tough or overwhelming. And I guess my last thing is, whether in prenatal care or in birth, it is important for people to know that there's always time to think. And when there isn't, you know, usually everyone is on the same page. And I think you can really, that's one thing that I think you can always ask as a client is, I just need to some time to think through what's going on, what my choices are, and all of that. And yeah, now we can do some questions.
Cool. I'm just going to turn my video back on because it feels more personal than being like a disembodied voice. Thank you so much, both of you. That was great. So I wrote down a couple questions, and I'm going to start with, I mean, I guess this is for both of you, or either one of you can talk about this. When do you start prenatal care? Like how many weeks pregnant before somebody should start doing that? I mean, clearly you can be thinking about it before, but once you are pregnant, like when does that start?
I feel like it's different with queer people than it is with like cis het families, because queer people, it's like very known and very planned. I think the earliest we typically start prenatal care is six to 8 weeks of pregnancy. With COVID, what myself and I think most health systems are doing is doing the first visit virtually and then doing kind of like an in-person visit around 12 weeks when we can do a lot of the other tests that happen around 12 weeks if you're choosing to do that. With like cis straight people, they might not even know they're pregnant for a little while, and then they would take a longer. So it's like sometimes that's more like 10 to 12 weeks of pregnancy.
Leandra, anything? You were nodding along. Anything to add to that, or is that?
No, yeah, I think that's pretty standard. I think the first appointment is really us like getting to know each other, getting to know your like medical history, your family history. And I think also what happens is that by week 6 and week 8, although some of us are very unlucky and get like the really nasty like nausea and vomiting and, you know, the stuff that maybe you can't cope with at home, you know, that sometimes necessitates maybe a little bit of an earlier visit because you're just so uncomfortable. But.
Great, thank you. Another question is, are home births normally covered by insurance, or how does the cost for home births work?
Yeah, that's one of the biggest barriers to home birth is we are typically not really recognized well by the insurance system, and it's very poorly covered to not covered. So in this area, there are nurse midwives who have some coverage for home births, but typically folks will pay about $2,000 to $4,000 out of pocket. And then with certified special midwives, it entirely depends on your out-of-network benefits, which means that, like, you know, you have to have like decent insurance to like hire to be able to get some or any coverage for home birth. And the best coverage I've seen has been about $2,500. And so just to give you a sense, the cost of a home birth in Philadelphia is between $5,000 and $6,000. If you have Medicaid, all of myself and all the other midwives have Medicaid discounts. So mine is like 35% off, which is $3,500. And then because of the pandemic and the way that it just really heightened the inequity about like who was able to like switch out of hospital care, we like started a birth fund that's myself and a few other midwives are doing births at our cost, which is like $2,500. And then we're trying to raise $50,000 to give grants to BIPOC pregnant people. And so far we've raised 40,000 and we have like, I think like 15 people who've gotten grants. Like it's pretty amazing. Awesome. And I'm hoping that's going to continue. And also that is part of our campaign to try and get like licensure and Medicaid coverage and a lot of things right now that like could change the state of home birth, but that's, yeah, like our model of care is like not prioritized and not recognized by the insurance system. So we typically, while it's like the third of a cost of a hospital birth, it often is a lot more out of pocket for folks. But it's a little bit different because like sometimes people will pay $5,000 to $6,000 for a hospital birth, but they won't know it because they don't get the bill until after they get home, and then they're like, why the fuck was I charged for holding
Right.
Yeah.
Right. And does that, and just a quick follow-up, does that $5,000 to $6,000 include the prenatal care appointments and all that care
Yeah,
too?
it includes all the prenatal care, the birth, and then 6 weeks of postpartum care. And that's also something that home birth, we do a lot more postpartum care than in a hospital system. So typically I see people 4 times in the first 2 weeks in their house. And then I do a 4 and a 6 week checkup in my office, which is like, I think like 600 times more postpartum care than you get in the hospital setting. Yeah.
Yep. And then if you were I assume if you were caring for someone who then had to have a hospital birth for whatever reason, then you would also still do the postpartum care for them.
Yeah.
Yeah.
Yeah. Typically what folks will do is like, they'll just pay for the care that they had. And then before COVID, I would go to the hospital with folks. I'd help them. Actually, I think, Leandra, I met you when I had someone who was like in labor for 3 days, and then we went in for an epidural, and it was awesome to be received by you after a very, very long few days. And so like before COVID, I would go with people, just kind of providing the same like continuity of care, advocacy, helping with like decision making from someone they really trust. That I'm now just doing on the phone, which stinks. And then when they're discharged, I resume being their care provider.
Got it. Great. And Leandra, I just had a question about when you were talking about prenatal care and you were talking about recommendations versus obligations. Can you give examples? Does that mean like ultrasounds, or like, for example, my wife had twins, and so we had so many ultrasounds.
Oh my God, I'm sure.
A lot.
Yeah. I think the ranges could go even from like a pelvic exam in your first visit, right? Like, is that something that you really want I have a couple of clients who maybe have had like recent miscarriages, and just any sort of exam in their genitals is like not something that they're looking for, when all they want is like reassurance that everything is okay and they're going to have a successful pregnancy. But and ACOG, the Association of College of Obstetrics and Gynecology, says that is like part of your first initial visit. So just those types of things. So from pelvic exams, in the beginning and towards the end, like, some providers really love checking that cervix, like even when there's no signal of labor, and how, like, who does that help? And is that a decision that we can make together with a client rather than like being forced to do it? Cervical lengths, like ultrasounds. I mean, I could go, and then there's like things like with a history of preterm labor, like people are sometimes told they need to do like the recommendation has been intramuscular shot, like weekly intramuscular shots from 16 to 36 weeks. And now people are backing out of something that we were telling everyone to do, and now people are saying, oh, maybe a weekly shot for 20 weeks during your pregnancy may not really be so great. But the number of people who maybe resisted that and then were labeled as like difficult patients or things like that, like even in my short time of practicing, it's unfair. And I think that is something that as providers in like a high risk and medical setting, we just need to be a little bit better about being a little bit more transparent of the choices that people have and the agency and the decision making that they get to do because they're the ones pregnant.
Right. Thank you. Yeah, thank you for that. And then another question from one of your slides, Leandra, you said people should think about if they want a gender affirming birth. Can you say more about what that is?
So I mean, and I think that where my mind was at was talking about like thinking about what a home birth would bring versus what a hospital birth would mean, right? Like having to disclose pronouns, having to talk about maybe even your gender journey with like a nurse who's like never had to encounter a trans person in their life or a non-binary person in their life, you know, and kind of being, I guess, understanding what those, what that mental and emotional load may mean, but the fact that you maybe are so afraid of what labor pains are like and really want that epidural, you know? So sometimes those priorities tend to be a little competing, and until we get to that point where I can guarantee a gender affirming birth in a hospital, you know, knowing that there's just so many people who you have to interact with, is something, you know, to really consider.
Yeah. I think and gender affirming stuff in hospitals, I think having a care provider that's willing to do some advocacy for you on the labor floor is a big deal. So like having your provider do a talk, like introducing pronouns, preferred parenting terms. Like having a couple of nurses on the floor. So this has definitely been done at like HUP, which I really appreciate, where like every single time I've transferred a few trans people there, and they like send in the queerest looking nurse and we're fine. And it's really like kind of amazing. Awesome. Where they're like, okay, like there's someone here who's going to be good at this, even if it's not everyone. And then like just thinking about, you know, like sometimes like having a door sign, like of like what are our parenting terms or language that we're using or not using for our bodies. It's really traditional to deliver babies to, like wearing your own clothes can be really helpful instead of like a hospital gown. And then it's traditional to deliver babies to the chest, but sometimes that might be more comfortable to do it to the stomach. Having like stuff around infant feeding in place. A lot of hospitals are really pushing like nursing and chest feeding as like the end all be all, but for like many families, it's like not actually good for your mental, emotional, spiritual well-being. So just like kind of having thought through like maybe the different parts of pregnancy and birth and labor that have to do with like the genitals and the chest, and if there's like needs around language, if you only want one provider to do exams, if no one else can be in the room, just like ways that, like it could be more safe and affirming for you, and having a provider that's going to help set that up for you in the hospital. In a home birth, like we can just do that. Like it's
exactly.
It's a lot easier.
Right. Totally.
Because you don't have like unknown providers.
Right.
There's not random people walking into your house during your birth.
It's like, you just like get me at 3 a.m.
Yeah. The only other question that I had, and I think you both kind of touched on it, but is there anything else? I mean, and we'll get to this question that just came in too. Is there anything else you want to say about how things have changed given our current pandemic situation? I don't know if there's, you know, you both. I mean, you mentioned this kind of telehealth visit for the first prenatal visit, and limited, like Ray, you can't go in the hospital with your patient, you know, with your patients. And then Leandra, you mentioned like there's fewer people. Like, I mean, I guess one question is how many people can attend a birth with you when you're giving birth in the hospital?
I will say this was, I mean, it was super concerning. I think when things were really bad in New York when it came to COVID, and just like where was it, right? It was Columbia, right? Presbyterian that got hit. Like there were like, it was a huge case study, and like the one case study that happened of laboring patients in a high-risk setting, and it talked about like 6 laboring patients literally all being infected with COVID and at the same time. And I think that just really struck a nerve and a lot of fear in people. Yeah. And there was a lot of conversation in Philadelphia about just not having any sort of like any visitors, you know, it was just going to be the person birthing and in a hospital room. And I think it was, that's where like the midwives and some of nursing honestly really went to bat for that. They were like, well, what if a 16-year-old like really needs her mom? Like, how can we say, no, you can't come into the hospital room? You know, like, what if it's just not fair? And also with all the hospital violence that does not happen outside of COVID, you know, we need chaperones, we need people to keep us safe. And that often is family members and partners. And our hospital never did that, never restricted visitors. It made it 0. We only have one person now that's able to come with the patient and stay there the whole time. But it was pretty scary.
Yeah, I
Sorry?
bet. Are the patients and like their support person COVID tested?
This is what's funny. The patient is for us, which has really made a really huge difference. It also has made a lot of ethical conundrums as to then if the person is positive, then what happens to their partner who's coming in with them? They're probably positive too, but we're not really gonna test them. We can't, do they leave? Do they come? Do they stay? And what we've ultimately done is just have them kind of be isolated in the couple of rooms that we have specifically for COVID positive people. I think the separation right now, the AAP, the Pediatric Association, has recommended total newborn separation from a COVID positive birthing parent. And that has been really rough, I think, for many families. They can decline it, actually. Our pediatrician has been a little progressive about this. We've talked a lot about informed consent and what that means. And so if a parent is no, I'm gonna keep my baby with me because I'm ultimately gonna be the primary caretaker.
You're gonna go home with them.
Exactly.
Right.
Exactly.
In a day or two, right?
Exactly. So
Yeah.
why am I gonna do the separation? So yeah. So and I think the biggest thing also is for prenatal care, we are not having any support people in some of our clinics come by for our visits or for ultrasounds either. So it's not been super great for some of our clients.
Yeah. There have been some changes in home birth too. I'm now doing half of my appointments on telemedicine. So it's online, in person, online, in person. And limiting people in appointments. I'm allowing one additional support person in appointments, but I'm screening both of them before they come in. And then I'm not allowing kids in appointments anymore, which really sucks because having toddlers participate in prenatal care is a very home birthy, sweet thing to do.
Yeah.
So
and then I'm having, right now COVID is a rule out for home birth because I can't protect myself. I can't protect the baby. It's people who have COVID in labor tend to get really sick right after they give birth, and they should be in the hospital in case that happens. So I'm recommending people do really strict social distancing to quarantining in the weeks prior to their due date to minimize the chances of,
right.
If they screen positive, they have to go to the hospital. And I'm doing one additional support person at home. So they can have a doula or a family member or something like that.
Yeah. Wow, so much.
Yeah, it's I think that isolation is the biggest thing for queer folks in pregnancy, and now everyone's experiencing that, and it's cool that there's more online community, but I think it's still really hard.
Yeah.
And also there's also you're not doing anything else, so why not have a baby in your house?
Right. Why not? You're doing everything else in your house. Why not? Yeah.
Yeah, just add a baby to it. It'll be great.
Yeah.
I just want to thank you both so much. We are going, for everybody who's attending, we are going to, Taylor, our intern who had to just jump off, is going to send out the recording, which I guess I can, I'll just keep it going. We'll send out the recording and then all the links and stuff that Ray mentioned. And Leandra, if there's anything that you, resources that you want to send around, you can email them also. People are saying thank you in the chat. Thank you so much, everybody, for attending. I'm going to plug our 2 upcoming sessions. So tomorrow, actually, Taylor at noon is doing an interesting talk about smoking, vaping, and the LGBTQ plus community. So that's about the history of marketing towards the LGBT community from tobacco companies and vaping, and that's part of the internship that Taylor's doing with another of the interns. So that should be interesting. And then next week's Path to Parenthood or maybe baby class, is about surrogacy, I believe. So for folks who are interested in gestational surrogacy or traditional surrogacy, I don't know, I'm confusing those words. If you're interested in surrogacy, finding out more about it, that's the session that's going to be next week. And I'm sure Taylor will, in the follow-up email, put links in about that as well. Cool.
Cool.
Thank you again, both of you, so much. We really appreciate your time and efforts and all the work you're doing for queer folks in the birthing trenches.
Yeah,
So.
and I'm really excited to see some queer birth working folks who are interested, who want to do this, because we do need it. You know, I think that's the one thing I would say, whoever's thinking about nursing school or anything, we need some like safe basis to touch on, especially as people interact more with hospital and out of hospital birth. And I put in my email too, if anyone has any questions about like professional stuff or like trainings, or you know, or even if they're wondering about hospital, you know, being a client for hospital midwives, I'd be more than happy to answer those personal questions.
Awesome.
Oh yeah, I can put my contact information in the chat too, and then I will say I do teach a class for people who are trying to get pregnant and lack sperm called Beyond the Baster. We're going to teach it online for the first time in, I believe, August 13th or 15th. I'm going to post it on my Instagram in the coming week.
Great. We can definitely share that too.
Yeah, and it's basically the ins and outs of how to track your cycle, how to get sperm, how to do inseminations, both with like a known donor that's like free and available, and also navigating a bank. So it's the DIY side.
Great.
It's a great class. It has great diagrams. Taught me a lot.
Awesome.